So thank you all for being here, and I'm very pleased to welcome to campus this morning Miss Mary Vance, who is with us this morning from Sevierville, Tennessee, where she serves as the Executive Director of Mountain Hope Good Shepherd Clinic. And this is a safety net provider in Sevier County, delivering primary care and other basic services for some of the most disadvantaged residents of Sevier County and neighboring areas, including uninsured and underinsured individuals. Mary has a very strong, relationship with our university and specifically with our college. She currently serves on our Department Professional Advisory Committee. She also works closely with the Sevier County campus of ETSU. And to borrow the term that my colleague Mr. Baylor said, she is a legend in her area when it comes to providing access to care and serving the uninsured. So we are very pleased, to have her with us this morning. And just like the best professionals do, she has no PowerPoint presentation. So that's exciting for a change, because I know you guys get tired of our PowerPoint presentations. So I'll turn it over to her, and thank you again, Mary.
Thank you. Oh my gosh, what a lofty beginning here. And thank you so much for having me here. And I see all of your young faces, and I'm just hopeful that as I'm getting older that you're going to take over my job. And that's the way that I'm going to start out, really. I was going to talk about some of the opportunities that you have, and especially in the area of safety net. And I do have a lot of experience in that area, but that's not where I started. And I wanted to share just a little bit about this start, because I hope that maybe in the position that you are right now in school, that some of my personal journey will touch a string of your hearts and your thought processes of where you are right now and where you might want to end up. And I started out in social work. That's what I always wanted to do, because I wanted to help people, and I thought that's where I needed to do it was in social work. So when I was 10 years old, I wrote to the Peace Corps. Now, this is telling my age just a little bit, because President Kennedy started the Peace Corps when I was 10 years old. So I always had that vision that far back. But again, and I never did join the Peace Corps, but I was a VISTA volunteer right out of college, and I decided at that time that I didn't want to go to another country and help people. I wanted to stay right here. So I kept that. After school, after college, and my undergraduate was in sociology and philosophy. And back then we didn't have all these different colleges that we do now, so they're a little bit more limited. So that's where I ended up. Didn't want to go into graduate school then, because I wanted to get out and work with the people. I wanted to find out, what areas I wanted to go into next. Well, in my social work field, I worked in a group home for juvenile delinquents, for girls. And I'm mentioning all these different things because in this path, this journey to where I'm at now, I learned different things. One of the things with that was being very patient, being very structured and strict. I found out that those girls wanted structure. They didn't have that in their homes, so they wanted structure. But the biggest thing that I learned about that was burnout. I got to where I had given and given and given so much that I couldn't give anymore, and it took outside people to tell me that. I was totally drained of all emotion. Couldn't laugh, couldn't cry. So one of the things, big pieces that I learned from that was now as executive director and having 16 staff members, 30 volunteers, all those folks at our clinic now, I don't want my people having burnout. It's really, really easy when you give and you care about people, and that's what I think sets our clinic apart from many others, is that everyone who is there cares about people, wants to make a difference. But every time you do that, little pieces of you come out, you give and give and give. Well, you've got to have another life outside of that. You've got to have a break so that you can rejuvenate, so that the next day you don't dread coming in, and that you're rested and you've got the energy to give it your all and give to people again. So that's one of the lessons that I learned there. Then I went, well, from the burnout, I got into artwork. I live in Gatlinburg, and that was just the perfect place to be. And I have my own business for 10 years, and I currently still live in the arts and crafts community there. And I got into airbrush painting. And that was just really a break. I had to get completely away from the professional field and get back into a creative part of me. So I actually even was a featured artist in the World's Fair. Not lots of people know that. That was just one of my past lives. And it took that 10 years actually for me to want to get back into the professional field. I felt like, oh my gosh, I've got a degree here and I've got experience and I'm not helping anybody except myself. But it took that long to kind of heal and get that feeling again. What I take from that experience is creativity. In what I do today, you really have to think outside the box. And I'm going to get into the different models of safety net. But again, I'm just sharing what I've been learning from my journey to this. From the artwork, I thought, okay, I've got to get back into the professional field, so social work again. So that's how I got connected with our hospital, our local hospital. They needed a part-time social worker. So I ended up with 3 offices, actually, because we had a nursing home that was connected to the hospital. So I had an office over there because I worked in the nursing home area. And then I had one in the hospital to work with the patients and discharge planning, things like that. And then I got into another department and that I developed, and so I had a 3rd office, but I was still doing social work then. Nursing home is, I went from working with juvenile delinquents, and I was legal guardian of 7 of them, and that was a challenge, I'll tell you, to working with the elderly in the nursing home. So there was a whole different population there. I really loved the nursing home. Not everybody, that's just not their niche, but I absolutely loved it. When you're in your 80s, 90s, you never think of yourself as old. That's one of the things that you gain there. They're not old. Their minds are still young. And the stories and the experiences that they can tell were just fascinating. And when you're there, you become their family too. There were lots of them who didn't have family members who visited very often, but we were there for them. It's not always the best conditions that you'd want, but that's why we're there, to help it be better conditions for them. So one of the things that I learned there was compassion. I would be with them as they died. That's not always an easy thing, and to work with the families that way. But with life comes death, and it's there for all of us. And so there's that other piece of compassion and caring and dealing with others. The hospital structure, being social worker, well, let me go on from the nursing home administration. I thought, okay, I really like administration and making policies and things like that. So I was approached actually by our hospital administrator saying, okay, we've got to have a hospital or a nursing home administrator separate from the hospital one, so would you like to continue in your studies? And I said, well, yeah, I would do that. So anyway, took more courses, marketing, accounting, just some basic courses, and then took a 1 year's apprenticeship at that time. I don't know if they still have that or not, but it was fascinating just learning about property management and everything, just the whole entire structure of things. Well, the day that I got my grade back from taking all these different tests, the hospital got a waiver so that our administrator could be administrator over both. So I thought, okay, well, that's all right. I like what I'm doing. But then they presented another challenge. How would you like to start occupational health? Well, I didn't know what that was, but it was working with all the business and industry and what their needs are. So again, that was listening to what the needs of people were, and that was a whole nother population of people. These were all businesses. Well, I started that department in the hospital. When I left to go into my current position, I had established a working relationship with over 1,000 companies. You wouldn't think Little Sevier County would have maybe 1,000 companies, but if you look at all the different McDonald's and, hotels, motels, restaurants, everybody, that's about 1,000. We don't have major industry, we have some, and of course I worked with them. Did all their physicals. We did drug screening. I had a 7-room suite of exam rooms, but then I had a whole another suite of offices right in the middle of the hospital. And one of the things that I can remember was where do I fit in the hospital? Because nobody really, other employees didn't really know what occupational health was. Well, she works with people outside, but, I don't know. And drug screening, the emergency room, they had to do drug screening. They didn't want to do that kind of stuff. They'd never had to do that before, and that was just another thing they have to do. And it's, it's very precise and of what you have to do. So I thought, we got nurses, we got doctors, we got, other people, and I'm not sure, sometimes where I fit here. But it took all those different things that I did in that journey to finally get to where I'm at now, which, see, if I'd have been in public health from the beginning, maybe I wouldn't have had to take that whole big, long journey, because I think what you are getting now in public health, and I just didn't know about public health back then, had no idea that I would end up doing what I'm doing. But instead of helping, we help individuals in the clinic, but what I really, really love is making a difference on a bigger level of policies, of advocacy, of running things, making possibilities and those opportunities to help the needs of people and the target population. So what I want to talk about today then is the safety net. And there is a definition of, it was very broad, but I looked at it, and excuse me, I do need to have my glasses. When you get older, you can't see. It's one of the first things to go. Healthcare safety net. Providers that deliver care in a variety of settings to a diverse group of people. Well, that's pretty general. But to be more specific in that, that includes public hospitals, community health centers, local health departments, free charitable clinics, some school-based clinics that deliver care to low-income, vulnerable patients. So that's going to be your keys there. I'd kind of like to explain a little bit of the differences in my experience and what I'm reading, but also in my experience, because I've been with the hospital. I work very closely with the health department, and my connection to them is actually in the beginning of my clinic, and it is a nonprofit 501c3 clinic, but I was chairing our local health council at the time. And I have since chaired the Regional Health Council, which is all 15 counties of East Tennessee. So I'm very involved that way and continue to be. Gee, it's a good thing they don't have term limits, because I've been part of our health council since we developed it in, I think it was 1995. It's not real active at this point. There's about 5 of us who have been there from almost the beginning. And it seems to be that the 5 of us who are really totally involved in the health in the community, we're on all the same committees and different active types of things in the community. So it'd be nice to have more, but another nice piece is that you know each other so well and what their strengths and weaknesses are, that we can do things and we don't even have to say, well, will you do this and will you do that? We just step in, we kind of know what each one's strengths are, and we go for it and we get things done. So that's a plus. And then, of course, the free charitable clinic, which is what I have. So I want to kind of talk a little bit about the differences in them. The hospital system, and this is public hospitals, and you've just had one hospital recently that's closed. I heard it on the news in Lee County, Virginia. Well, there's probably going to be more hospitals that'll close, and especially in Tennessee. Hope not, but hospitals rely upon a different kind of fee structure than my clinic does. They get commercial insurance, and of course, Obamacare. If everyone has insurance, then that's going to help. That'll help tremendously if the hospitals don't have to support all of those self-pay is what they're called. People who have no insurance, so they're paying themselves for everything. 100%, I'll point out. But they also get, they have the commercial insurance, they get Medicare, Medicaid reimbursement, although it's certainly not 100%. It's what those reasonable and customary charges are. I remember in the business office trying to figure out what that was, and nobody would share it. I'm not sure if there was ever really any fee structure there at all. It's just what they felt like paying at the time. But they do a lot of charity care as well. Now, some hospitals have certain kind of funding. They have to take the charity care, and they get some grant money back for it. Many hospitals also will have foundations that help to foot some of those bills and to pay for maybe some of their equipment, maybe their structure to add on to a building. So they have that help. Where it's going to hurt our hospitals now will be for the state of Tennessee is not expanding Medicaid. So they're going to lose a lot of money that way. That's going to be one of the biggest challenges for our state, is that not expanding Medicaid. That's going to affect everybody and greatly affect us. We're going to have more patients. The health department, now I'm just going to go over the hospitals and then the health departments. The health departments get, of course, they're part of the state health department, but they also can receive some federal money, and they also receive local government money. And then they do charge for some of their services. So, but they will charge on a sliding fee scale, and particularly their primary care units. They didn't used to do primary care. That started in, I think it was about 2006, 2005, 2006, I believe is I'm losing track of time, but that's when we had some major challenges, and I'm going to get back to that in a minute. So they do get, in their sliding fee scale, they have also a 0%. I wanted to point that out. And is there a sliding fee scale out there, a pie in the sky, that's the set sliding fee scale? Well, no, there isn't. There is for the state of Tennessee, but anybody can pull up any kind of sliding fee scale that they want to. That was one of the things that I learned, because I thought, okay, where is that sliding fee scale? I need to find it. And so in our clinic, when we first started, we did a sliding fee scale, but we stopped at 10%. We didn't go down to 0 because my volunteer board of directors felt that people should pay something. So we didn't have a 0%. Then we come to my clinic, and clinics like mine, but I'm going to speak specifically about mine, we serve only the uninsured. So we take no insurance whatsoever. We started in 1999, February of 1999, all volunteer. I was still working at the hospital then. I helped to develop the clinic. I was chair of the health council when a couple of folks approached me and said, we'd like, if it's possible, could you guys do a survey in the community to see if there would be support for clinics such as what we envision. So I helped to orchestrate that. Yes, there was support for that, and that's what grabbed me. I like to organize things and develop things, and here was a chance for me to help people again. Occupational health was kind of helping people, but there wasn't any real personal touch in there. It was strictly business. I had 2 other departments at the hospital as well. I made the maybe mistake, but I ended up loving it, and it was my favorite thing to do in the hospital, was employee health. I had a positive PPD one year, TB test. Well, I had so many questions, and I'm the one to research everything. So one of the administrators, I said, this could be handled a little bit better. I'm always for improvements. And so they gave me the department to run. So I think in our whole system, and I was part of Covenant Health, when I left, I really feel that that we had the best employee health program in the whole system. We did health risk analysis with my folks. I got into physical fitness type things, and I knew every one of our over 400 employees by name, because they all came into my office and sat in my office with them. I loved that personal touch of being with all those employees. Then my other department that I was chair of was community health, and that's why I had that involvement. It was just natural to go into from the health council. This is another thing I'm going to share with you in your journey, not to do. At one time, I was on 21 different committees, and I chaired over half of them. That's crazy. So in your journey, don't do that, okay? But as my staff will say, Mary, you're always an overachiever. You're doing all these different things, but oh boy, you've got to be on top of your game. And you remember I said you need to have a life out there, so just be very careful of getting involved in so many different things. There are always needs out there, and one person really can't do it all. So I had those 3 departments, and then developing this clinic over here. And I was doing that kind of on my, if I had any of my own time, that was kind of my own time. I would run down to this little volunteer clinic to do orientation with new volunteers and different people, and I would use my paid time off to go and do that. And then it hit the newspaper that we were opening, and it said that I worked at the hospital. So I went to my minister and I said, oh, I didn't mean to get the hospital involved in this. I've been doing it on my own. And, I was just kind of concerned. And he said, Mary, my God, don't take paid time off for this. This is a benefit to the hospital. So I got the blessing. Of course, I knew I was doing that, but they figured I'm running 3 departments. How much can I abuse time, for helping this other little clinic to get started? But start as we did, we had our first budget of $800 back in '99. And of course, next February will be 15 years that we've been open. We've grown a lot since then. As I said, we started out all volunteer, open 3 days a week. I would go down at night when I left the hospital and put charts into the computer and do different things. After, well, it was 2001, we were in the final completion stage of a 6,000 square foot building that was being built for us by an anonymous donor. And I was really losing sleep, because remember when I said in this journey of all the things that you learn, well, with occupational health came all the OSHA, ADA, all those different things. So I'm thinking, the people who were building this building were just building a building for us. There wasn't any patient flow in mind. There wasn't regulation of stuff that I learned from nursing home administration, of, how wide the hallways have to be, your doorways, the access, all those things. And I honestly was losing sleep. I could not sleep. I was so stressed. I was so afraid I was going to miss something. And this was critical in the development of this building. I went to the board of directors, and I was on the board, of course. And I said, I can't do this anymore. Somebody has to be in charge. And I had already hired help. We finally had some employees, and I did all of that, and all the orientation, all the stuff that I learned from hospital things, and hospitals are structure. It's very good learning experience. But all the things that I learned from that, and somebody's got me in charge, can't do it. And they said, well, why not you? And I said, well, I still remember this. I thought, I don't know if I could do just one thing. I was so used to juggling so many things. I thought, I don't know that I could do one thing. And of course, I was very passionate, still am very passionate about this clinic, and I wanted the best person for the job. So I was in church that next Sunday when I had announced that to the board, and everything that was said in that sermon was like a hammer hit to the head. If I never got a clearer message ever in my life, I got it then. And when I walked out of church, I thought, okay, I've got to put my hat in the ring here. I think this is what I was supposed to do. I think everything that I've done in this journey has led up to this. And I quickly learned when I was chosen, and I made sure that, I had set up all the interview criteria and everything from all the people that I'd hired before. And I said, I'm stepping back. I was chairing our personnel committee for the board, and I said, I'm recusing myself from this, and so I want this done the right way. I don't want any favors. I want the right person for the job. So we did have several applicants. I was asked to take the job, and I did. When I told the hospital administrator, there were tears of joy on both our sides, and we still work very, very closely together. Her comment to me when she was giving me a hug was, it had to be you. It had to be you. And this is merely an extension of providing health care for the community. So we will work even closer together, and we have. So those are those good types of relationships and partnerships that you gain in these. We could not operate at all our clinic without these partnerships. But how is our structure different and funding? I talked about hospitals. Now, hospitals get everybody, okay, and they get the charity care as well. The health departments get funding from the state, from the federal government, and from their fees from county government. How do we get our funding? Well, it's completely different. Remember I said the creativity of thinking outside the box? Well, that's where a lot of that comes into play, and where the social work comes into play of working with people. And especially in partnerships and working with our patients and the different factions that you've got to deal with in a community. And remember, one of my departments in the hospital was community health. The occupational health, working with the businesses and industries, because I still work with those businesses and industries, just in a little bit different approach. Now I ask them for money and opportunities to help us with fundraisers. We do charge fees. As I said, we had a sliding fee scale. We don't anymore. We get safety net grant monies, and I'm going to go into that in just a minute. But we get safety net grant monies, and with that, and that's through the state of Tennessee, we were audited, which is a good thing. You want to be sure that wherever the money is going, that you're doing the right things with it, what you're supposed to, in the right way. So I'm one of these people who welcome audits. I'm sorry, I know I'm weird. I'm one of those overachievers. I even read everybody's bylaws. I write bylaws, I read bylaws before I even join an organization. I'm just into that kind of detail. But I always want to know what I'm getting into. But in this audit, he said, I'm looking through all these charts. Everybody's paying $20. Where's the sliding fee scale? And I said, well, I'll tell you. My front office staff always say, when they say, well, how much is it going to cost? Well, we don't know what it's going to cost because it's sliding fee scale. So you have to come in, we have to have proof of income, and then we'll determine what your charges are going to be. But just go ahead and bring $20 at a minimum. Well, everybody was bringing $20 as a minimum. There were some of those people that were in the higher brackets who would bring in their proof of income, but there was probably a larger majority of people who didn't bring in their income, so they're at 100%. We know that they probably don't even have any documentation to bring in. They don't make enough money to file tax returns, so where was their proof of income? So $20. Everybody's paying $20. So he says, well, you know, nothing says that you have to have a sliding fee scale. He said, why don't you just have a set price? Everyone's paying $20, just set a price. I said, would you put that in writing as a recommendation that I can take to my board of directors? Because, oh my gosh, this is an answer for us. It's embarrassing for people to have to bring in their proof of income. And to stand in the front and in the window, it's a barrier. It's hard enough for them to come seeking care than to prove themselves of where they're at. So that was wonderful to get away from that. It was also great for my staff because they didn't have that nightmare of always trying to keep up with things and, well, you still didn't bring this in, you need to bring this in next time, your proof of income. So that was wonderful. So that got rid of a lot of the paperwork, a lot of the time that it was taking. There is one area in which we still must ask for proof of income, and it's not our requirement, but we work very closely with pharmaceutical companies to get medications for our patients, and they all require that proof of income. But that's a person that I have dedicated to that position to help people, and so she's the only person that has to deal with that. So there's none of that at the front office, which is great. So we batch price everything. So office visits are $25. Whether they're new, established, doesn't matter. They come in, it's $25. Dental, because besides the medical, we do dental. $20 a tooth. That may seem kind of weird to batch price that fee. You know, when you get into your health care, you're going to see all these ICD-9 codes and all these different codes for different levels of everything. Well, since we don't take insurance at all, we don't really have to deal with that. Not at this point. But when I set up the clinic, we do have ICD-9 codes. We do all of that. Because if we ever have to convert or change, and plus that's a way to kind of compare apples to apples when you're doing things. So it was much easier to go with the flow of everyone else in healthcare. But we certainly don't have all those different levels. And so $20 a tooth, that includes the dentist time, the x-ray. Doesn't matter if it was easy or hard to pull, if he had to do sutures or if it just fell out. It's $20 a tooth. People know what to expect when they walk in through the door. We can tell them that it's $20. It's not usually life-threatening, so we do ask that they come with that money when they walk in the door and be expected to pay it. So if they've got a whole mouthful of bad teeth, well, you know, you got $40, we'll do 2 teeth this time. So we kind of look at it that way. Even what might seem a little bit more bizarre is the safety grant money. We've got dental. They pay by the tooth. I always thought that was kind of strange, but we give them a report of how many teeth they pull. Yes?
How do you prevent abuse? When you're receiving a safety net grant, specifically for serving a certain population, without looking at income, and without having a sliding scale fee, how do you prevent? Because this that gets around that it's $20 for a visit. How do you prevent not considered medical population from coming into the clinic and using the services that we provide? Is there a way that you do that, or do you suspect that may happen? Or?
It happens sometimes because people want to stay with us. We are their medical home. And what we're having to deal with the most right now are people who are reaching the age to receive Medicare. And we have to take them off our rolls. And that's really one of the biggest ones. We take people who have no health insurance, period. if they live or work in our county. So, and we don't check to see if they've got insurance, but if we happen to write a prescription and they go to a pharmacy and hand a card, then the pharmacy calls us because we've just got a good working relationship with them. If they're at 100% because they make so much, well, there may be circumstances why they still can't get insurance. And hey, if they want to try to become one of our patients, that's okay. You know, there's reasons that I don't have the time to ask everyone. It's extremely difficult to get into our clinic. This is one of the challenges that I was going to get to, but we have over 18,000 patients of record now. Just people who live or work in our county. And we are turning away, we are down to turning away over 700 people a month.
New patients?
New patients, mostly new patients. So, you know, if they want to try to be one of those first persons to call in and be accepted as a patient, then, you know, we, like I said, we don't have the time to see if they're, why. You know, it's just if they don't have health insurance. Batch pricing. Now, I'm a numbers person too. I'm in everything there at the clinic, so I do all the accounting, do the payroll, do HR, do property management. You name it, I do it. I have, you know, I can walk in that building with all the lights off and know where everything is in that building. In fact, I've had to do it with the police one time, and I was just barging ahead, and I thought, I'm in front of him. I need to get behind him, because our alarm had gone off. So we were checking through, but I knew where everything was, and to see if anything was missing. But at any rate, in my numbers, I have found that we actually collect more money now than we did with our batch pricing for everything than we did when it was sliding fee scale. Because they know what their expectations are, what it's going to be roughly when they come in through the door. Now, our labs, this will blow your minds if you don't know this, of what markups are on different things in healthcare. That's some of why we have the issues that we do. What costs me, I have insurance. What costs me for my normal labs, just basic labs, between $300–500, just for basic labs. We charge our patients $30. We take what our cost is from our local hospital, what they charge us, and we round it up to the next dollar. So it costs me between $300 and $500 for basic labs. It's $30 for our patients. And in the collection, what I said, we receive more money now than we did before, but of the fees that we do charge, 90% of it is paid by our patients. That's unreal. If you would ask any other business, you know, hospitals or anybody else, what do you really receive from your self-pay? 90%, that's pretty good. Of course, now those are discounted fees. Does that meet my expenses? Not close. I run at a deficit of $55 for every visit. Now, what kind of a challenge would that be? Now, I talk to a lot of businesses and groups and leadership classes and stuff, and they're all in business. And I said, now, how could you run your business where every unit of service that you provide, you lose? Would you still be running that business? It's a challenge. That's one of the biggest challenges that we have. So how are we going to make up that difference? Well, fundraisers. remember I said this creativity, think outside the box, and partnerships with people, and working with business and industry, working with the community. Well, we have developed, ETSU was a major partnership. We now have every third-year medical student from ETSU School of Medicine rotating through our clinic. Now, does that help with the money end of it? Well, yes and no. But anyway, I'm going to get into that as far as opportunities. One really major partnership was with Food City. Well, how do you think that helps our clinic? Well, I met with the director of the pharmacy for all the Food Cities and showed him the clinic. We went out for lunch. He was on the phone. We sat down. He said, "Mary, write this down." I said, "Okay." And he said, "Well, this is a name and a contact number for the pharmaceutical company that I use for all of Food Cities, and they're setting up an account for you, and you are going to get the same prices that I do at Food City, and I'll be your guarantor." That was nothing out of his pocket, but it was that partnership. And we saved last year, I haven't done the figures for this year yet, but last year, what we saved from their wholesale cost, what their wholesale cost was compared to what they charged us, we saved over $1 million last year. So that's money that I didn't have to spend. Our patients cannot afford their medications. If you know, you've got access to care to emergency rooms, but just like dental, for instance, they can't pull a tooth in the emergency room, but they'll give them pain medication and antibiotics. Well, they'll give them prescriptions for that. Well, they don't have money to pay for that. So, you know, what good has that access to care really served there? So we have a lot of drugs at our clinic. We have a sign on the front door saying that we don't have, you know, prescriptions or the narcotics. We have a sign on the door that we don't prescribe it, and we don't have it on the premises. Well, we do prescribe just a little bit, especially on the dental side. I mean, you know, you're doing a surgical procedure on some of them, just really yanking out those bad teeth and digging in there to get those rotten pieces out, and you know, there's a reason for those pain medications. It's just not abused. We give just small, you know, whatever they need. So there's a need for us to have lots of medications, and I was adamant, have been adamant, and this is what we do. If anybody needs an antibiotic, they walk out the door with it in their hand. There's no prescriptions given for antibiotics. We keep those on the shelf at all time. It's $5. They can't afford $5. We don't turn anyone away for inability to pay. So they walk out the door with that medication. We've got a formulary of the drugs that we want to keep on the shelves, just, you know, regular drugs, kind of generic, the cheaper ones, because if that works for them, they can't afford a more expensive one. So we're very conservative, but we keep all those medications there. So that's where this partnership with Food City really helps. That's just one of them. Sheriff's Department with the county, they mow for us, they weed eat. I use the jail guys. They come with their deputies and keep a close eye on them, because when I need furniture moved, if I need the floors stripped and waxed, I got to move all that heavy furniture. Boy, I can just bring in those guys. They whip it out in about 30 minutes. They've got it cleared out. Gets them out of the jail. While they're there, I talk to them and say, this is a place you can come if you don't have health insurance when you get out of jail. You know, if you don't have it, this is where you can come. it's been kind of nice and helpful in one way, because I remember one guy, he was, I think, community service, and they let me watch over him, so he just had to come and report to me. And that's when we were first working on the building, and I needed things put up, and they said, well, he's pretty trustworthy, you know, he won't run off on you or anything. So, but anyway, he ate with us. We've got a huge kitchen. We have a lot of meals there together. We feed people. They're hungry, they smell food, we let them eat in the lobby. But I remember this guy saying, boy, you're good people. You're good people here. You help other people. I'm going to make sure nobody in the neighborhood messes with you. So, so see, you never know what advantages that you have of just being good to somebody, of how it can come back to help you. So, the fundraiser, you know, I talked about those kinds of partnerships. Fundraisers, we have several each year. It was nuts this last year. I had 5 fundraisers plus RAM clinic. Have you heard of RAM, Remote Area Medical? Do it. Get involved with that. I had all that in 4 weeks. That's another crazy thing that I'm warning you. Don't do certain things. Don't overload yourself with all of that. That was nuts. But we had one of the neatest ones, and again, this was partnerships and getting community involvement, was that the Lumberjack Feud in Pigeon Forge, and we're lucky in one way because we have all these theaters and entertainment and hotels, motels, restaurants, you know, and working with business and industry, remember occupational health? We serve their employees. So it's kind of payback. Okay, we're helping take care of the health of your employees, so why don't you help us with some fundraisers? Because most of your employees are coming to us. So I kind of turn it around that way. So Lumberjack Feud, they're kind of new. Has anybody heard of them? Okay, well, boy, talk about creative people. They wore me out. I mean, they were just ideas and changing and doing things, but it was so much fun. I kind of got outside my administrative in the office paperwork job. But what we did, you know, their premises, they've got, I think, the Dawsons against the McGraws. So you got the red flannel shirts versus the blue flannel shirts, and they're competing in lumberjack activities. Well, the cool thing about the Lumberjack Feud is these are true professional lumberjacks. I'm learning things every day. They even had ESPN there filming national lumberjack competitions. So it's a big deal. And these guys are the true professionals. So as part of their show, we pitted the firefighters against police. So we had a representative of firefighters and police from the city of Gatlinburg, Pigeon Forge, Sevierville, and the county. So they had a representative from their police department and then a representative from their fire department. So they were competing against each other. And oh boy, are they competitive. They are extremely competitive. And then we had training sessions with them, with the real lumberjacks. They are it was successful. We made about $25,000 that night. And we had celebrity servers, because it's a dinner theater too. So we had celebrity servers who were there and trying to get tips. And of course, all this money came to the clinic. We had an auction going on, and live auction and silent auction, and we had everything that we could. But oh my gosh, that was fun. That was fun and different. And we've already got the date for the last Monday of January coming up. And the firefighters and the police are already getting ready. So, you know, this is community involvement. So you you know, we had a little blurb about the clinic there, but we also had kind of a testimony actually from the owner of the Lumberjack, who said why this was important to him as the owner to do for us. I mean, because he put out a lot of money for this, and so, you know, it spreads, and that's a difference of really being in that community and getting community support. Now, in Safety Net, you've got community health centers. I feel like we're really the community health center because we have to really rely upon the community for our funding. Of course, with other funding, we have grants that we write for, that we write proposals, United Way, locally, through churches, foundations, different things. So we're always scrambling. I have a full-time fund development person who works on putting together all these fundraisers. I can't do it all, and we write grants together. She'll put together a draft. I'll say what I want to go for and what feeling I want in this, what I want portrayed, and then we work together to massage it. Another way in which we save money is by volunteers. Now, I have 16 paid staff. Remember, we started out with all volunteer at $800 our first budget. Well, my budget now is, I haven't done the one for 2014, but for 2013 it was $764,000. So a long ways from that original 800. Gone from all volunteer to 16 paid staff plus a dentist on contract. But also have over 30 active volunteers. All of my doctors are volunteer. All of them. And they are top-notch physicians. So that saves us a lot of money. Lots of nurses, front office staff, landscapers. You know, we could not operate without our volunteers. Not at the capacity, of course, that we do now. There's no way. So it's crucial, very crucial to have those volunteers. So, you know, our structure for free charitable clinics is different. Now, let me go back to the community health centers, because, you know, they're put in there with that getting Safety Net grant money. The community health centers have to fill certain requirements to become a community health center, and they're pretty stringent. You have to work with vulnerable populations, and you know, I ran off what those criteria are. There's 4 pages of it, so I'm not going to go through all that. But the difference in their structure and particularly their funding compared to us as receiving Safety Net grant money is that they also must take Medicare, Medicaid, commercial insurance. So there's 26, and I do have those statistics. Let me see where I put it. There's 26. Well, I don't remember where I put it. There it is. There's 26 community health centers in the state of Tennessee right now with 190 different sites. 41% of their patients are uninsured. Okay, 41%. So you can see what the difference is. They've got people that are coming in with insurance of some type that they're getting reimbursement for. So they can receive state money through the Safety Net grant money, and they also receive federal money. Well, in the very I guess probably about the third or fourth year that we were open, as executive director, I must do a good job of informing my board of all opportunities. So I brought someone in from the federal government to talk about the differences. Did we maybe want to go down that road? We could get more money in, we could see more people. But we didn't want to get away from our original mission of just serving the uninsured and underinsured. So we decided not to go down that road. So we don't receive any federal money. So the only, we do get local government money. All 3 cities and the county give us money. It's pretty nominal. I think Pigeon Forge gives us $6,000, Gatlinburg $6,000. That doesn't pay for 1 week of payroll. But you know, I'm grateful. I'm grateful for anything that we get. So those are some of the differences in the funding. Now, the federal government, under the Affordable Care Act, the federal government is going to really shore up and give more money to these healthcare centers, community healthcare centers. And I'll tell you why that they're going to need to do that. One of the challenges that we have, and I better quickly wrap up here. One of the challenges that we have is that, and especially in our county, when people get their insurance, where are they going to go? There has been no providers in our county in the last year or two that has taken any new patients. So if they're not taking any new patients with insurance now, what are they going to do with all these thousands of people who may get insurance? Well, they're saturated now. Where are they going to go? Well, we are still going to remain the same and just take the uninsured, because there are always going to be uninsured folks. There may be even more uninsured folks because of the Medicaid deal. But where are they going to go? They will need to go to these community health centers. And that's where the federal money is going in, even in structure, not only just adding more people, but adding on to their buildings. So these are existing health centers that will get this extra money. Anyone new who's coming in and decides, like I might, I think I'll become a health center now so that I can get more money, they're not going to put that affordable health care money into those new facilities. But it stands to reason that that's a good place for them to put that money, because there are community health centers across the nation, and they have set regulations to do what they do that they must comply with. So there is that structure that's the same. It's different with little clinics like ours. We don't even know exactly how many there are of us in the state of Tennessee, because we're not structured. We don't have an association yet. We're working on that. We just had actually a meeting this spring, and we had, I think it was 14 representatives of different ones, but we tried to come together with a directory, and we came up with 37 so far free charitable clinics. But they're in little pockets. We're all kind of standalone. So you kind of do your own thing, but you're really focused on your own population like we are. So our population is different. We don't have as much homeless, but we've got low wages types of jobs that are there. So one of the other, I want to just wrap up with some of the challenges. I've mentioned there are so many people who need us, and there's not as many healthcare grants out there available, and many of our donors, our local donors, think Well, everybody's going to have insurance. Why do we need to support you anymore? So we've got to do a lot of education that there's still going to be that need. Our population is changing just a little bit in that we need to, I've just had to hire 3 interpreters, Spanish. We have a lot of Eastern Europeans also in our area, but most of them can speak English. But the Hispanic population is growing, and that one of the reasons for that too for us is that the health department, starting last October, a year ago today, is that they've got to show documentation to get into their primary care. Well, even if they have the documentation, it's scary to them, and many of them don't. I don't check documentation. Till the day that I have to, there's no way I'm checking documentation to see if somebody's legal. If they're sick, we take care of them. That's my stand with that. Dental is a huge need. There's nobody else that's there's very few of these clinics that also do dental. And if you participated in RAM, you know that's one of the big needs out there is dental. Let me tell you one of the biggest rewards. Of course, you know that you're helping people. You know, as I started out in my talk, I wanted to be a social worker at age 10. I wanted to help people. We're helping people. We're helping people in a big way. One of the extra perks that I get in my job is that I get to witness other people giving. I'm going to tell one just very quick story, but I was having the front end of our office remodeled for security reasons, and there was a fellow there, he's putting in glass windows. And I said, well, this, you got a little challenge here because we got patients who are coming in and out, and, talked about HIPAA and confidentiality of what you might hear and all that kind of stuff. And he said, okay. Well, I left and came back, and, my office manager, as soon as I walked in the door, she's waving this piece of paper at me, and you've got to see this, you've got to look at this. And I thought, oh my gosh, what is this, a bill, an exorbitant amount or something? And she said, just look at this. I said, okay. Well, he had marked it off, no charge. And she said, well, the guy just says no charge. And I said, okay. Well, I thought I better call the company to be sure, because I wasn't, this guy just handed this to us. And so I called the company and I said, were you aware of this? Well, yes, we're the owners of this company, and that was our son. And I still get choked up here. She said, this is the first time in his experience of being there and hearing what people have to experience, where they are in their lives. This is the first time that he ever really understood that. And he called us to see if we could donate. That's powerful. So, sorry, it still gets me. That was a while ago. That's why I do what I do. This is the opportunity that you all have in public health, that you're going to have this opportunity to help lots of people. You can help individuals, you can help lots of people. You heard my story of all the things that you're taking all the classes right now in public health that are dealing with all those things, and this is the good opportunity that you have. And I was just saying of how impressed I've always been with ETSU, because they go out and they ask people like us, what is it that will make our classes better and prepare our students for going out into the community, going out into these different careers, and be effective and be well equipped? Well, that's why I've shared these different things. In public health, oh my gosh, you're getting all of this. They're trying to develop their curriculum for you to do all these things. You're going to have the opportunities and internships and jobs, and we do public health internships at my clinic. Haven't had any in a while. We were just talking about that, and if anybody is here who called me the other day and left a message, you can talk to me after class. But it's I commend you. I encourage you to stay in this field. The opportunities are endless, and you can see all the different things that you can touch and do in your public health. And there's job opportunities through different associations that you can look at on their websites, and if you need any of those, I can pass them on. So,
boy, wasn't that inspiring.
Sorry, I didn't leave much time for questions.
That's okay. I think you've answered. So thank you very much, Mary. This is just a small, token of appreciation.
Oh, thank you.
We are out of time. Thank you all for your participation, and we'll see you first Tuesday of November.